Our next speaker, and I'm delighted to introduce last but not least, the parallel state of the science speaker, who's a surgeon, Dr. Nadine Haram. She is an NHS surgeon. She's a lecturer and clinical entrepreneur and has received the British Empire Medal in the Queen's Birthday's honor. Nadine really drew on her passion for innovation, education, and global surgery to find Proximie. And I really, really invite you to look up the website of Proximie and listen to Nadine's videos. It's really inspirational and exciting, and I'm really glad she's with us in person. So Proximie is a technology platform that allows clinicians to virtually scrub to any operating room or cath lab from anywhere in the world by empowering clinicians to share their skills in real time. This allows us to reduce variation in care and ensure every patient receives the best health care every single time. Proximie allows multiple people in remote location to virtually interact in a way that was not possible before and really mimics the reality experience. And they can show each other where to make an incision and how to best guide surgery. I won't say more because I really don't want to steal the show of Dr. Haram. And it's wonderful to have you with us, Nadine. The floor is yours.
Thank you so much. It's a pleasure to be here, and what a great talk before then. I definitely stressed my my cerebral muscle and my cerebellum muscle today. But let me just open up my screen. I hope you can see this. Yeah, fantastic. Well, you've heard clearly a lot of the science and the intelligence around AI and machine learning, and I hope today, during my presentation, what I can share with you is more of the clinical application and the benefit we see perhaps or the opportunities in healthcare that can be truly meaningful in how we transform and reimagine the delivery of healthcare, and in my case, around surgery. So as you very kindly pointed out in my introduction, I'm a surgeon by training. I'm a reconstructive plastic surgeon, largely focused on breast and pelvic cancer, which was my main area of expertise. But as a surgeon, I've always been very frustrated with the status quo. And we'll share some pictures that illustrate this, but largely that stems around the challenges around variation in outcomes, variation in access, variation in care. And of course, the opacity of the operating room. You know, having spent more than 10,000 hours in an operating room, it's clear that this environment is still very opaque. It's very hard to extract knowledge in any meaningful way. There isn't a clear data pipeline that helps us leverage it for knowledge sharing and skill delivery and acquisition. And of course, the increasing issue around supply and demand of clinical expertise and the patients that need it. And so I want you to picture and imagine a future where operating rooms are connected, digital, immersive, and collaborative. And that's really the future that I want to share with you, where we can start to really bring complementary components, bringing together the best of human expertise with the most advanced solutions and technologies like those that you've heard about today, to change and reimagine surgery. And I think we must, you know, the caveat I would say to everything I present today is I'm a true believer that innovations and technologies and softwares will complement the clinical practice and workforce, but will never replace surgical teams or surgeons. They're just going to enable us to really scale and augment what we do at a different pace. Now, a few years ago, I was asked to be a commissioner on the Future of Surgery Commission here by government and the Royal College of Surgeons. They asked us to map out, you know, what will the future of surgery look like in the next 5, 10, and 15 years. And we wrote this paper back in 2017, 2018, where, you know, we were definitely seeing innovations and technologies touching surgery, but nothing like what we've seen since COVID hit. And back then we identified some key themes and thematics around this, around computer vision and AI and machine learning, robotics, of course, and, you know, potentially elements of autonomy in surgery, and also the immersiveness of augmented reality and virtual reality, and of course, big data and genomics as we started to shift towards more personalized medicine, which, you know, we've heard a bit about today, and this is something we see as a continuing theme in healthcare. And how do we make sure we're treating the right patient with the right clinical, you know, management plan that's bespoke to them? But I want to share that this all comes on a really significant backdrop, a backdrop where today 5 billion people still lack access to safe surgery. And this was published by the Lancet Commission. A shocking number, an unacceptable number, really. And the fact today that, 2/3 of the world's population doesn't have access to basic surgical care, to me was something that was unacceptable. And I knew that we needed to really disrupt the way that we deliver surgery in order to address that challenge. We needed to take what has been designed for a moment in time. These are typical operating rooms that we see, anywhere in the world, where they are designed about physical co-presence, analog, undigitized, not really rich with information and data, to a new world where these rooms are connected, collaborative, intelligent, immersive, and data-driven. Let's take this picture, which is a great picture from the history of surgery. So the picture on the left kind of shares a lot of what I love about surgery: the camaraderie, the collaboration, the communication, the fact that we are coaching and supporting each other through a case. And that was, from, at least 100 years ago. And we fast forward to this picture from DeBakey's operating room. I'm sure many of you know DeBakey, a famous of Lebanese heritage, cardiology and surgeon who was out in Texas doing this case. And you can see where the problem is. We're still doing much of the same. We haven't really evolved our process. We assume that just by putting many people in this room, this is the way to share the knowledge. This is the way to do this in a seamless way. And I'm sure you'd agree that this is not conducive to scale. And more importantly, this is going to introduce a lot of variation. Each one is going to assume what they want from this environment, and then we'll go and apply this in their clinical environment thereafter. So I'd like to share with you a video. It's a bit abstract, but I hope for the scientists and the engineers on the call, it makes sense of what a reimagined data-driven surgery looks like. Imagine a global network of borderless, digitally connected operating rooms, brimming with the world's best surgeons. Intelligent operating rooms, unburdened by geography or time, where every single interaction is recorded, connected, reviewed, and stored to shape and improve best practice. A digital continuum of surgical expertise designed to reduce variation in care. Every touch, sound, piece of technology, every patient outcome. The paradigm of surgery and healthcare is changing. It is being reimagined by the operating system of the operating room. Proximie is a centralized platform designed to scale expertise beyond the four walls of an operating room. This once analog environment is now a digitally connected and data-driven operating system designed to improve global healthcare, creating a platform that brings the best surgeons, AI technologies, and application partners into any operating room around the world. Connected surgical care. And so, AI is often perceived, at least as a frontline clinician, as a supplement, not a replacement for the skill of human surgeons, but the possibility of bringing and augmenting and driving more intelligence, more information, and sharing of that knowledge in a different way. And we'll talk about a couple of use cases as well. And AI also has the potential, I believe, to transform the way surgery is taught and practiced. And there are elements, if we were to take a particular procedure, there are elements of a procedure that could be done in the future almost autonomously, such as closing a wound or stitching two vessels together. And so there's possibilities and opportunities in taking this knowledge and codifying surgery in a much more meaningful way. Today we still see a high amount of variation in surgery. It's not really codified. And so rather than there being 1 or 2 ways to do a procedure, we still see 14 to 18 ways to do a procedure. And therefore, what that results in a high amount of outcome variation. Today in the UK, you're 14 times more likely to suffer complications, for example, in colorectal surgery between one hospital and another. And so how do we drive and take that intelligence in a different way? I think it's also important to know that 4.2 million people die within 30 days of surgery. And half of these occur in low and middle income countries. And the number of post-operative deaths accounts for about 7.7% of all deaths globally. I mean, that's the third highest contributor, which I think is often underestimated or ignored. We focus a lot more on heart disease, stroke, diabetes, infectious disease. But what about surgery and the outcomes around surgery? What we also know is that there is enough evidence on the market today that has demonstrated that video-based training or video performance metrics can truly optimize and improve the learning curve and reduce harm to patients. And again, we just start thinking about how we use this data and knowledge in a more meaningful way, both for prevention and prediction, but also for intervention and management, improving quality, improving efficiency, lowering the cost of healthcare, and really trying to better understand what's going on holistically in an operating room. And Proximie, the software that we designed, really enables us to do that, because what Proximie does is it's a software that enables you to capture video and data, collaboration, communication from every operating room. It enables you to virtually reach in and collaborate and share best practices. And there are many videos online that demonstrate this. It enables a doctor in one place to virtually reach in and support a doctor or a nurse in another place. And that's really the future of how we want to think about leveraging this opportunity in this rich data environment. I want to give you a really firsthand practical kind of thinking that came to mind to me in 2014 and 2015 as I started to imagine digitally connected operating rooms. I knew that the future had to be data-driven, immersive, intelligent, smart. But I also knew that if I was going to walk in next door to one of my colleagues and say, I'm going to build you the AI engine for the operating room or the OS of the operating room, they would probably not really understand what I was talking about or feel there's any relevance in it. But if I was going to walk in and say, hey, I'm going to help you reach in and collaborate with your colleagues. I'm going to help you be more efficient with your time so you can run a clinic while your fellow's in the operating room. I'm going to help you telementor and telecollaborate in a way that's never been possible in surgery. Then with that approach where there's immediate value, you have a much higher chance of success in getting surgical teams more comfortable with audio, video, data capture, recording in operating rooms because they're getting immediate value. And on the back of that, start to aggregate and crowdsource probably one of the richest surgical data sets in the world that can be meaningful for clinical teams, for software developers, for health systems, and many other parts of the health ecosystem. And of course, the application of AI in healthcare is very broad. And you've heard a number of examples today. We've seen this in imaging, in robotic-assisted surgery or autonomy, but also in remote monitoring, detection, et cetera, et cetera. And the development of these skills are, of course, helping deliver the increasing opportunities for the health sector. But I think we're really at the very, very early stages of where this is going to go. I would say, as someone practicing, we're only seeing early snippets of, what the benefits of AI can be in surgery or in healthcare more broadly, be it in radiological diagnosis, remote monitoring, prediction of patients, and of course in surgical codification. And when we think about AI across the surgical sphere, we need to think more broadly. It's not just about the intra-op moment or the moment in time when the surgeons are operating or the surgical team is working together. It's also pre-op and post-op. It's how are we optimizing data collection pre-op, for example, for prehabilitation, for prediction of patient outcomes, for looking and crowdsourcing the knowledge, the imaging, and the information meaningful for that case. Intra-op, of course, how are we using it to track performance, to track tissue deformation, to identify critical insights that may be relevant to the procedure, and potentially drive, robotics and autonomy in the future. And then, of course, is the post-op. How are we now collecting optimization of the OR, or better patient outcomes, or surgeon performance? Or can we start to use these algorithms to better understand scheduling, or supply chain optimization, or many, many other tools that we have yet to connect across a continuum? And my argument would be is a siloed approach doesn't solve a systems problem. Truly, and with all respect to any engineers and those working in the development of these technologies, it's only one piece of the puzzle. The much larger piece is actually the behavior change, the winning of hearts and minds, the value-based approach. One can build a very sophisticated algorithm at their bench, but delivering that and changing clinical practice is much harder. And I think that's the bit where engineers and scientists and clinicians need to come together in a much more cohesive and comprehensive way to really reshape how we do this. And of course, not ignore the challenges we have around bias, around affordability, around scalability. And we're starting to see some interesting opportunities even around federated learning sets and others and how we try to drive that. But, I would even argue the sustainability of the algorithms long term. So there's still a lot more work to be done, but the clinical applications are becoming exciting. And we're even looking at things like, well, if I'm recording and capturing video in the operating room, can I better understand tool utilization? Does the surgeon need just a standard knee replacement set, for example, or can we optimize based on the utilization of their historical 50 cases? Can we better understand the equipment orders that are happening and then stock and manage services and supply chain accordingly? So you're not sitting on buckets of stock that's out of date. Can we start to better understand detection of cancer in a meaningful way? And this is a really interesting example that I'd love to share with you. As many of you know, colonoscopy screening is pretty routine in our approach to colon cancer screening, and we use colonoscopy as a standard, as well as fecal occult blood and others in the older population. So in the UK, in a part of Wales, there's a big teaching hospital in the center of town, and then peripherally there's a lot of smaller hospitals and the colonoscopies are run by nurse technicians and endoscopy technicians. Whereas in the big teaching hospital, they're run by the clinical teams. So in these peripheral hospitals, oftentimes, if these technicians see a polyps, they will automatically refer that patient back to the big teaching hospital to have another colonoscopy, to decide if that needs to be biopsied, and then to biopsy it. Now, from a patient experience, it's pretty awful to have to go through that clearing of your bowel twice, which of course can affect your kidneys, and in older patient populations result in dehydration, AKI, and other problems. But also the cost inefficiency, the delay to diagnosis, and the reduction of benefiting of the efficiency of resource that you have. So what we did is we deployed Proximie across all these hospitals, and we connected them to the hub, very similar to an air traffic control system. And we had these experts dialing in on their laptops, on their computers, into these peripheral centers and guiding, as you will see from the video with their hand, a demonstration around what is normal or abnormal. Over time, of course, because we were labeling basically directly these videos, we were able to create an algorithm that helped identify which polyps were most likely hyperplastic and therefore should be biopsied. And therefore, we were able to redivert this first kind of time to diagnosis back to the peripheral centers where these nurse endoscopists were better supported and trained to have decision-making tools that supported them to biopsy these polyps, improving the patient's journey, improving resource utilization, and improving time to diagnosis. And of course, we partnered with technologies like 5G to think about how we scale that even further. And one other interesting project we've been looking at is how do we better understand efficiency in the operating room? Imagine we could actually work and capture the time to skin, time to send, the putting the patient to sleep, the positioning, the draping, and the patient's observations alongside that. And so we see a future where all these tools can come together and really change the way we drive surgery and deliver surgery, as Proximie can truly be the operating system of the operating room, the eyes and ears of the operating room, helping us drive and better understand the data, connect clinicians to drive better care, but also make sure that we're driving better training for our clinical teams and training for our algorithms as well. And really continuing to build on a connectivity, a global web of connectivity. I would love to stop here, but happy to take any questions if needed. I have a hard stop, I'm afraid, so maybe 1 or 2 questions, but I'll have to jump off.
Okay, Nadine, this was amazing. Thank you so much. While I'm looking at the chat, I'm going to take a stab at what you started approaching. Can you project the impact of technology like this on health equity?
Yes, I mean, what's really important is understanding that when we think about 2/3 of the world's population lacking access to safe surgery, we need to think of other ways to scale the delivery of care. And these are tools and ways that we can do this, where we're able today to actually dial in to Kenya to support in the delivery of safe surgery. And we're supporting in obstetric surgery as well. We're now being able to connect experts around the world to make access to surgery more available than it's ever been. And it's not just about surgeons, it's about healthcare workers, nurses, midwives, and many others in the field that need the support as well.
How expensive is it to set them up to be able to be taught and trained distantly?
That's the beautiful part about this. Proximie is designed to be vendor neutral and hardware neutral. So you could, if you have a phone, tablet, computer, you do need a smartphone, but beyond that, we know that actually smartphones are quite ubiquitous in the world, even in the most austere of environments. You're able to actually dial in and work with doctors and nurses as well.
So there are a couple of more questions from the audience. Do you think of developing Proximie to extend to clinics and ambulances?
Yes, we're doing some work actually in trying to support in the field, because with a tablet, if you're in the field, you're able to provide more input from the hospital to the field and back. And we're doing some work working with the UK military as well and supporting them in the field and field services too.
One more question. Is Proximie already implemented? I think the answer is yes. And where is it implemented in the world? And I saw in your video several countries worldwide. Can you just tell us a little bit more about that?
Yeah, so Proximie is deployed in over 50, 60 countries, more now. We are in over 500 hospitals, and we are supporting the delivery of care. We're doing thousands of cases. We've done over 10,000 so far. We are anywhere in, Europe, the Middle East, the US, Asia. What's exciting for me personally is that we actually have an office in Beirut where we have at least 30 members of our team. A lot of our engineering and our developments happening on the ground in Beirut. So, we're very excited for anyone interested in collaborating or being part of this journey to please reach out to us as well. We'd be delighted to get people involved.
Yes, and it would be amazing in war zones where people can't get the care they can get. So Dr. Dao has posted the Proximie website. I really invite you to visit it to look at Nadine's videos. I know you have to stop, Nadine. We enjoyed having you in person. We look forward to more of that.
Thank you.
We're going to stop here, and I want to thank all three speakers, really. The introductory slides are on the website. I apologize they were not showing. I'm so glad that Nadine could join in person, Marin could join in person, and we look forward to continuing conversations on these important topics.
Thank you for running the session. Thank you.
Thank you so much, Professor Fuleihan. With this, we reached the end of our event today. I would like to thank all the stellar speakers that joined us today. I would like to, before we end, to thank the organizers of this event. First, Professor Fuleihan, thank you so much for organizing the health session with Dr. Lina Daou. And thank you, Dr. Mariette, for organizing the first session. I would like also to thank the comms team, Yara Haddad and Diana Matar, and Ms. Abir Sinno, the Strategic Initiative Manager. And of course, I would like to thank Layan Sarkis, the Admin Affairs Manager, and Hani Shahabuddin, the Audio and IT Specialist, who helped us put this event together. And finally, thank you all for attending today. We'll see you next year.